Hi everyone, Abhijit Manas here. In part 3 of the shoulder impingement video, we're going to discuss things that you probably want to consider when trying to assess what kind of an impingement your patient could probably have. So there are a few things that you could consider in this. I find history taking and your special tests in your examination might give you a good indication on what kind of impingement your patient might have. So let's talk about history first. In an external impingement as compared to internal impingement, the history seems to be a little different. A patient might come in with insidious onset of pain or might have a particular incident that might have caused this, say working out in the gym, doing too much of the same kind of exercises which might have triggered it. But it kind of gives us an indication of which way the impingement might be going towards external or internal. With symptoms like insidious onset, the pain started slowly over the last couple of months, or when they were doing some kind of a particular exercise which caused pain, you'd probably want to think maybe lean towards external impingement. Internal impingement, however, is rather different, in which you'll see a lot of athletes or players, for example, somebody playing doing a lot of overhead motions in their sports, like say volleyball, where somebody's about to serve, or think about squash, tennis, the moment where you throw the ball up and you're really trying to either hit the ball or the shuttlecock, where your arm goes into excessive amount of external rotation, or even fielding in cricket or bowling or baseball, where there's repeated motion in external rotation, that gives you a pretty good hint on which way the impingement could be leading towards. One of the other things that I also consider is the site or location of pain. In external impingement, a lot of times the site of pain is more on the anterior part of the shoulder, and in internal impingement, generally patients complain of more pain in the posterior superior part of the shoulder. So in this part of the video, I'm joined by my beautiful wife, who's going to be the model for this video. And given the circumstances we are in, I'm shooting all these videos from home, so I don't have the most ideal setup. So a lot of these special tests I'd probably want to perform in supine position as well. Some of them in sitting, but some in supine. But here goes. So the first test that I'd like to talk about is the knees impingement test. The knees impingement test is basically full internal rotation of the arm and full arm flexion, right? So say if I'm trying to test her left side, I'm going to place one hand to hold the scapula down, have her arm onto the side, get into a full internal rotation, and then trying to raise her arm into full shoulder flexion. This is a provocative position, and any pain that is reproduced in this position would be a positive sign for the test. Again, the pain generally patients complain of is more on the anterior part of the shoulder. The second test that we're going to perform is the Hawkins-Kennedy test. The Hawkins-Kennedy test, in the Hawkins-Kennedy, this is the first, the starting position is arm on the side, shoulder in about 90 degrees of abduction, and then I'm going to slowly try and move the arm into internal rotation here. Again, if you want to see that if you want to determine if the impingement is more on the anterior part of the shoulder, I could also bring the shoulder more forward just like that, and then try the same thing again, almost in a scapular plane here, and then bringing it a little further, right around here. Again, reproduction of pain in the anterior part of the shoulder would be a positive sign for this test as well. The next test that I'd want to perform is the empty can test, which is basically getting the arm by the side of the body, and then we're going to try to get the arm in about 90 degrees of shoulder flexion and in the scapular plane, and then have the patient perform internal rotation almost like an empty can, and then I'm going to try and push the arm down, and I'm going to ask the patient to resist my force or just meet my force. So don't let me push your arm down. Any reproduction of pain during this motion, again around the anterior part of the shoulder, would be a positive sign for this. Relax, thank you. And for internal impingement, the test that I like to perform is almost the same provocative position that might be causing this problem, which is repeated external rotation, right? So in this position, ideally I'd like to perform this test in supine, but unfortunately we'll have to do it sitting on the chair here. So in this, I'll bring the arm into 90 degrees abduction, and then get the patient's arm into full external rotation as far as we can go. And this test is pretty similar to the anterior apprehension test for dislocation. The only difference being in anterior apprehension test, the patient might complain of pain more in the anterior part of the shoulder or discomfort in the anterior part. In internal impingement, this would cause compression of the articular surface. If you remember, the articular surface of the rotator cuff with the glenoid rim, and the pain is more reproduced at the posterior part of the shoulder. One of the things we also find commonly in this is that the humeral head tends to anteriorly translate a little bit. So a lot of times, if you give a slight posterior push in this position with the arm in external rotation, the patient might report a slight reduction in symptoms or even the pain going away. And that would give us an indication that this might be internal impingement.